I'm not going to be getting on a flight to Russia and rolling up my sleeve for their vaccine. So perhaps technically I'm wrong. There is an approved vaccine. The reality is that any vaccine that's been actually tested using normal standards is going to have side effects, is going to be hard to take, and the efficacy is not going to be what we ultimately will have for efficacy 6 months, 9 months down the line. When you first release a vaccine, the vaccines are full of side effects. You can see in the small studies of a few dozen patients that have been done, they've all been done in healthy young volunteers. Healthy young volunteers require 2 doses of the Moderna vaccine and have a lot of side effects. Now, when they tested among 30,000 people, I imagine there will be many more side effects in people who are not young and healthy. And those are the people we want to protect first. So as much as if it's a perfect world and everything happens right and we have a vaccine released that we actually trust and believe in the Western world, or in the Eastern world, in China, by January, it won't be ready for prime time. We won't have enough doses until at least 6 months later, at any scenario. And if you ask people that question, will it be ready? Will it lead to herd immunity and all of the things that we really need from a vaccine? I think they will agree. When you ask the question, will we have a vaccine? People will say yes. We have been talking about how do we control this virus, and there are differences of opinion. Do we go on one end with total containment and eventual elimination, like New Zealand, like Taiwan, and like some other countries? Or do we go toward herd immunity, like Sweden and Brazil, which allows the so the opportunities between one end of the spectrum, which is not allowing, which is letting the virus run rampant and trying to get everyone to herd immunity, has serious consequences. We've seen how many people die. The rates of the virus in the community reflect how many people die in nursing homes, how many of our vulnerable don't make it. On the other hand, we've seen very successful control. Thank you. Next slide, please. And next slide, please. And so we've seen very successful strategies, including opening and keeping schools open in Asian countries who've tried successfully with containment. And so right now there's a false choice between lives and livelihoods. Do we save lives or do we keep people working? It's a false choice. You can have both. And we know what that answer is. And it isn't herd immunity, which is a nice clean term for saying we're not going to try to fix anything. We're going to just let everything go on as normal and ignore the science. Next slide, please. So what do we need to actually reopen safely? This is not rocket science. You could make this slide yourself. We need an early warning system. We need broad and efficient testing. We need effective quarantine, treatment, data, and vaccines. Let's go to the next slide. So what is an early warning system? This is an example of an early warning system. 1.5 million smart thermometers in America that at the first sign of illness, you take your temperature at home, it creates a signal that is captured on the internet and tells you where there's unexpected fever hotspots in the country. This early warning system gives an 18-day early warning, a leading indicator, early warning of where COVID is in the community before you wait for someone to get sick enough, feel bad enough to get tested. Tests, by the way, take 3, 5, 7, 10 days to come back now. Show up at a healthcare system, get admitted to the hospital, and die. Right now, we're relying on lagging indicators. People dying from COVID, people waiting to get hospitalized for COVID, waiting for cases to turn positive, versus a leading indicator that has been validated now across the country in every city that they've looked with 12 to 18 days. This is not rocket science. It's simple. It's a thermometer that connects to the internet with some predictive analytics on whether it's flu or COVID, along with a symptom checker in the app. These are the kinds of things we should deploy across the world, frankly, in my opinion. Next slide. Efficient testing. This has been one story of a disaster after another. We're actually doing less testing today in America than we were doing just a few weeks ago. The hope is that antigen tests, which are low cost, instead of $50 or $100, they only cost $5 to $15 once they're at scale, at the point of care with a turnaround time, which means from taking the test to getting the answer, 15 minutes perhaps, right? That is what we need. There's going to be a lot of these tests available. There are going to be many stories about how confusing they are. The short version of the story is, if you have an antigen test and it comes back negative, you're more likely not to have the disease. If it comes back positive, you're not so sure. That's a broad generalization, but there's a lot of information on testing out there now. Please stay tuned for antigen tests and how they will help us across the board. When you have a normal test, a molecular test, something you've heard called PCR for diagnosis, coming back 3, 5, 7, 10 days later, by that time the virus has already spread. It's less than useless. And our government has created this problem by paying people $100 for this test, as opposed to the $50 it actually costs them, and paying people even if the test results come back 3 or more days later. They should not pay for a test result 3 or more days later with a COVID test. Next slide. And the slide is blank. No, go back. Effective quarantine and isolation. This is the state of affairs in America. We don't have it. We know what we need to do. Other countries are giving 2 weeks of free Netflix. So when you're stuck in quarantine, you have something to do. They're giving hotel rooms. They're taking people away from their families, because intra-family spread indoors in a tightly packed environment is how a lot of the spread is occurring. And we don't have systematic ways to do effective quarantine or isolation in America as of now. Next slide. Treatments. A lot of treatments are being made. There is not going to be one treatment that works. 169 treatments in various stages of development right now. And we will find that, for example, steroids, cheap, in use for many years, decreases death by 20 to 50%, depending on the population. That's a big deal, and it's a cheap medicine that's been around a long time. Remdesivir and others all will help add incrementally so that our death rate goes down. And that's the short story on treatments. All of these slides will be available to you. All of the data and links are available on every slide as well. Next slide, please. Vaccines. So the one approved, I'm not going to line up for. I hope you don't either, in Russia. But there are about 39 in phase 1 through phase 4 of study, which is optimistic. There are other studies around repurposing of the BCG vaccine, which I'm not describing here. But this is a story of success where science has moved quickly together to find many different potential ways to create a vaccine. Again, no hope for any time in the near future. I'm personally not optimistic that we'll have widespread availability of vaccines until Q1, at least Q2 of next year. Next slide, please. And this goes into some of the details of the most promising 5 vaccine candidates. And I won't go into more details here other than to say that this is going to be hard to prove, right? You need to test a vaccine in a place where there's a lot of COVID going on. So they're rushing to try to recruit people where COVID is going up. Only then will you see, is a vaccine effective relative to not getting a vaccine in preventing spread. And so the numbers are staggering. 30,000 people need to be enrolled for a study. That's very hard to coordinate, very hard to do. And that's why I'm saying, don't hold your breath, be optimistic, but let's wait and see what happens. Be very measured. Next slide, please. A lot of metrics and data. We talked about needs for data. This is a group called Resolve to Save Lives. Former CDC head Tom Frieden is one of the leaders of this. These are some of the 15 metrics he talks about that we need to be talking about and reporting publicly daily at the state and local level if we can. We're doing a horrible job of this. Horrible job. As a nation, we do not have a good reporting system. Even as you've heard the stories publicly about the CDC versus HHS reporting data, we really need to start to think about a fundamentally different approach to this that protects privacy and still allows for public health to do its work. Next slide, please. This is one of the examples of actionable data at the US level for 3,000 plus counties. And it tries to summarize some of the most important metrics of 5 indicators: the daily new case count, the infection rate, how many people are testing positive, how much room do you have in the hospital, do you even have tracing capacity in a state. And this tries to give decision makers easy ways to understand, are you at risk? Are you actually in an outbreak, or are you doing well? You can see most of America still has an R naught or RT of greater than 1. They're yellow, orange, or red. Only 2 states have an R naught of less than 1. And so that means that we are not anywhere close to doing well. Next slide, please. I'll stop there.